Welcome to Scope It Out. In this edition, Dr. Smith will be speaking to Dr. Jayakar Nayak about his article, Use of Intranasal Submucosal Fillers as a Transient Implant to Alter Upper Airway Aerodynamics, Implications for the Assessment of Empty Nose Syndrome. This episode of Scope It Out is made possible by support from Medtronic. Medtronic's enabling technologies help you perform sinus and skull-based surgery using powered ENT instruments, surgical navigation systems, and balloon sinus surgery tools. Through innovative technology integration, Medtronic brings surgical synergy to your OR, facilitating operative efficiency, value, and outcomes. Visit www.medtronic.com/ENT to learn more.
Hello and welcome to Scope It Out, the podcast of the International Forum of Allergy and Rhinology. I'm your host, Dr. Tim Smith, and today I'm very happy to be joined by Jayakar Nayak from Palo Alto, California. We will be discussing his article, which is currently available online and entitled Use of Intranasal Submucosal Fillers as a Transient Implant to Alter Upper Airway Aerodynamics, Implications for the Assessment of Empty Nose Syndrome. Jayakar, welcome to the podcast.
Well, thanks for the invitation, Tim. It's great to be here.
Absolutely. Empty nose syndrome has gotten a lot more research attention, I feel like, in our field over the last few years. And I think that's a credit to you and some others around the country and even around the world who've been working on this very challenging condition.
I, too, have been pleasantly shocked at the outpouring of interest, abstracts that are submitted to our national meetings now, discussion that's openly being had. I think more than just a few years ago, it was more of a taboo kind of subject and something that we didn't necessarily give much credence to or much attention to. So I agree. I think people say that I might have, and my group's efforts may have had something to do with that, but I think it's also just some of the new, techniques and some of the ways that we can test these patients out have led us to try to put more science and quantitative metrics to some of the research that we're doing.
Yeah, and you guys, I think, are doing that very successfully. I get the sense that these patients do a lot of research, and they come to find you and others who have specifically done work in this area. And so your experience in seeing this patient population, I think, is greater than the vast majority of our listeners. Certainly it's greater than my experience. So I'm wondering, could you start just by describing from your perspective, what is empty nose syndrome?
Sure. I think everything you said is true. I think first of all, these patients do just use social media. They use Facebook forums and other websites that have been around for years, actually, finding each other, finding doctors who are willing to see and treat their possible symptoms, at least help them along the way. And then there's a few of us in the U.S. who are interested in actively seeing these patients. I think we all know each other, and also the community of possible patients seeks us out, like you're saying. But empty nose syndrome, to be brief, is a controversial condition, I think it's fair to say. But it's associated with the disruption of the sensation of airflow and altered air conditioning functions and sensory functions in the nose that afflicts patients, especially those who have had turbinate-related procedures, usually to the inferior turbinate and sometimes to the middle turbinate.
And why is it controversial, Jayakar?
Well, it's controversial because the nose is a very subjective place. It'll always be that way. Very simply, some people have severely deviated septums, for example, and you'd think that they would complain of nasal obstruction or nasal congestion on that deviated side, but patients don't many times even know that they have a problem on that side. They just don't perceive an issue. Similarly, if a turbinate is, let's say, partially or completely resected, something called a turbinectomy procedure is performed, there's a fair number of patients who would actually not have any issue with that, it seems. They thank their ENT physicians for the procedure. They went in for nasal obstruction. Now they're less obstructed and they're less congested. They're sleeping better. They're breathing better. They're improving their activities in life. And so
would you hazard to guess that that's the majority of patients actually that could sustain a let's say, a total inferior turbinectomy and say that actually that helped me? I'm not advocating this by any means, but do you think more people get away with it than don't get away with it?
Well, I mean, from what
I've seen,
we know? Yeah, I think that what our research is indicating, what patients have taught me, and I probably have I've seen over 115 or so consults for specifically just seeing me for empty nose syndrome and whether they have it and can anything be done about it, is that a few patients have said immediately after the surgery, after, say, the Doyle splints or the packing material sometimes came out, they sensed something wrong. They couldn't feel the air in their nose. They felt immediately that they were suffocating. That's maybe 4 to 5 patients in total. Everyone else had said something like between 6 months and 6 years. They developed a slow progression of symptoms and a slow decline. I call it the decline delay. So they had a slow onset of symptoms that are bothersome, and they don't put it together necessarily as being related to that distant now turbinate procedure back when they had it done. So that's why I think it becomes mysterious. And also then sometimes they've moved. Sometimes they've changed insurance plans, things like that. So they don't necessarily go back to the same doctor who performed the initial turbinate or septoplasty turbinate procedure. So I don't think we really know what the frequency is of this. The incidence of it is, it's considered rare. 1 in 1,000 patients, 1 in 750 patients might get this after a turbinate procedure, but that's general numbers, but I'd venture to guess that it's actually more patients if we really parse them out. And I'd say a good number of my patients actually didn't have turbinates, really had few complaints. They came to see me for something else. I happened to see the tissue loss in their nose. I then did things like a cotton test, which we can talk about. But then they noticed, well, they didn't have complaints, but they love their nose now that they have more resistance or more material in their nose. So there are patients like that. So again, the spectrum of what patients will complain about or notice even in their nasal cavity after procedures are performed is so wide-ranging. That's why it's this controversial condition, and one I think that needs much more investigation and study.
Gotcha. Now, the vast majority of these patients have, in your experience, the empty nose syndrome is the result of, would you say, over-resection of the inferior turbinates primarily? Is that a fair statement?
I think, yeah, first let me just say that there's an entire category that we're not going to probably talk about, which is primary Torvik rhinitis, where patients seem to, especially in less developed countries, that an infection-related atrophy of the nasal tissues, including the turbinate, leading to crusting and other general breakdown, no nasal procedure involved. So I actually don't think I've seen a good number of these patients offhand, maybe 1 or 2 who have traveled from the Philippines just recently, one who's domestic who said he's never traveled to another country, just have crusting, severe crusting and breakdown of tissue in their nose. Okay, so with that said, the majority of patients that we see in the U.S. and North America are following partial turbinate loss to the inferior turbinate, and sometimes near total to total inferior turbinate tissue loss from actual, I think, clipping of the turbinate, sometimes radiofrequency ablation of the turbinate, a variety of procedures that can be performed to reduce turbinate tissue, sometimes lead to excess tissue loss.
Okay. And so this patient population, then, I guess I should say you also see patients who have empty nose syndrome based on resection of other tissues in the nose, other turbinates in the nose, or septal perforation. What would be, other than inferior, inferior turbinates, what else causes empty nose syndrome in your experience?
Right. So we consider it, well, Stephen Hauser is really the forefront, at the forefront of doing this. He's at Case Western, and he really named several subsets of empty nose syndrome. Again, the majority that he sees as well are inferior turbinate related. He's also described something called the empty nose syndrome, ENS, of the middle turbinate. And I wasn't sure exactly how to evaluate this until someone just came through my practice who had never had inferior turbinate surgery and only had a middle turbinate resected as part of a procedure to his sphenoid sinus, the posterior most sinus. This central turbinate, the middle turbinate, was resected, and he had an abundance of debilitating and life-altering symptoms that he'd never had before. And so we've done a middle turbinate procedure to help him to try to restore the volume and the bulk of the middle turbinate on him. And that's when I started to believe it, because his symptoms and his quality of life have greatly improved, thankfully. And then I don't think that septal perforation is in the spectrum, per se, of empty nose syndrome. In fact, I have probably a controversial theory on some of the importance of the nasal septum, per se. But I think when nasal septum tissue is lost, it can lead to sometimes noisy breathing, such as whistling and things like that, but also sometimes it can increase discomfort because of the vectors of airflow that are flowing through the septal perforation that normally would be flowing in a single direction. So these abnormal and turbulent currents through the septal perf can lead to not only bleeding and crusting, but also can lead to some symptoms that are associated with nasal pain and facial pain. So again, empty nose syndrome is not just about, it's mostly, I think, about airflow, but also about the sensory difficulties that go along with altered airflow. Some patients complain of something called paradoxical suffocation. Even though their nose is more open because of the turbinate tissue loss, they say that they're more congested, right, and they're suffocating. And that's the classic symptom. But some really don't complain of suffocation, even though they have the same tissue loss as others, but they complain of nasal burning. The dryness is really what bothers them. The throat discomfort is what bothers them. So, and then suffocation is less of a problem for them. So I do think it happens like any disease to be a spectrum of symptoms, that all of which can be encompassed right now by this term empty nose syndrome.
So why is it that one patient can have their inferior turbinates, let's say, completely resected and describe a good outcome, and another patient could have their inferior turbinates completely resected and end up with empty nose syndrome, which is clearly very impactful in an adverse way to their quality of life? What's the difference between those two patients, do you think?
So it's an outstanding question, and one that we're trying to answer. I call the population that don't have symptoms but don't have turbinates as a silent empty nose syndrome patients. And we are studying them because naturally they're the most fascinating group. It seems to me that they either are just remembered how congested that they were and realize that there's enough airflow going through the nose that they're not obstructed. Maybe they had such difficulty with sleeping because of turbinate congestion that now they're sleeping better, and most of the things that were bothersome to them prior to surgery are now alleviated, and it's okay. And so even if they have, let's say, a B on the A through F grading scale, that's better than what they had pre-op. The other thing is that sometimes when you have a total turbinate tissue loss, you're symmetric. At least you have symmetric tissue loss, right? And so you don't sense any change.
No discrepancy between the two sides.
Right, there's no, right, exactly. So I think of turbinates like wings of a plane. For some people, clipping the wings of a plane leads to the plane completely going awry and the airflow being completely disrupted, and their plane, i.e. their nose, does not function ever again.
Right.
Whereas other people, you clip the wings of the plane, they're fine not flying at high altitude, but they're fine just sort of coasting along, and they don't have paralyzing, debilitating symptoms. And then some of those patients, I have a bunch of these silent ENS patients, for example, in my practice, and a few of them can convert in a way. If you test them and place cotton again in their nose, I have one or two patients who just woke up in my office. They just said, oh my gosh, I didn't have any complaints. Their score on our scoring system was very low, as if they were normal breathers. But then they said, don't ever take that cotton out of my nose. This is so incredible how well and open and clear I'm breathing. So I do think that again, there's so many compensatory mechanisms that humans and patients can invoke to help with their quality of life, and I think that happens in some cases. I think that again, there's going to be patients who are just thrilled, and their subjective sense of their breathing is so much better than pre-op. There's going to be some who could be better, but they're happy with that B or a C on the scale, and there's some who unfortunately get this. and get remarkably disabling symptoms, pain, and then the sense of suffocation leads to a sense of anxiety. Anxiety probably leads to loss of sleep. Loss of sleep leads to depression, and it just is a downward spiral that decline what we're discussing before.
Yes. In the number of patients that I've seen, you really describe that, what I've seen, very classically. Honestly, it really is a spiral, and how it impacts these individuals is very remarkable. So in this study, you have used a transient resorbable filler that's been used in the larynx before. We have a lot of experience with that in otolaryngology and treating patients with vocal fold disorders of various kinds, and you've used it in the nose primarily to recreate some portion of the inferior turbinate, it would appear. Is that fair to say?
That's right. Yeah, the general idea was that I have patients now, fortunately, who are coming from over 20 states in the U.S. and then 5 or 6 different countries. They're flying in not only first to get evaluated and to confirm that they may or may not have this diagnosis, but then they don't want to necessarily leave without something being done. Mm-hmm. But it's super difficult, as you might imagine, to just, if I haven't met them or counseled them on the phone and done a lot of preoperative counseling and work, to just go to the OR. And
right.
So what we often do is, for these patients who, again, come from a distance and either want to have something done but aren't sure about the next steps in their care, for example, should they proceed with a turbinate implant, and I can tell you about that later, instead of doing something like a cartilage graft or alloderm grafts or other things that are performed out there, can I try something out that gives me a sense of what I might be getting into? So just like in laryngology, before you put in a permanent vocal cord or vocal fold filler or a bulking agent to restore voice, it dawned upon me that we should do the same thing for patients who are either in between in terms of diagnosis. I'm not sure what they have. Mm-hmm. In between in terms of confidence. They're not sure they want to proceed with something because, in a way, surgery got them into the situation.
Right.
And then sometimes just because we need to process their insurance and take some time, they want to think about it with their families, but they want to try something out that's similar to an implant. We dawned upon this filler injection, which lasts on the order of 6 weeks to 3 months in the nasal cavity, and it gives them a sense of what they might feel if they went ahead and proceeded with surgery. And sometimes it helps confirm the diagnosis when I have a patient who's kind of in between. Their score isn't perfect on our scoring scale. Their exam isn't perfect when I examine them. So things like that, I think it's a nice confidence builder for all of us.
Yeah, it's a brilliant idea. Are you doing this only on the lateral wall of the nose, or do you do it into the nasal septum at times?
Right. So, I mean, I've always felt that. So first, let me backtrack. So the treatment for empty nose syndrome, when you have tissue loss, is the thought that tissue replacement or a reconstruction of areas of the nasal cavity where the tissue has been lost is likely a reasonable next solution to helping those patients. So I know Dr. Hauser, for example, that same physician in Cleveland, has done lateral implants into the inferior meatus, where the inferior turbinate typically is, and the tissue has been lost. But he's also done implants on the nasal floor, nasal septum. For me, I've always felt that we should just replace the normal configuration and contours of the nasal anatomy. So I try to only do this for the most part, in the inferior meatus. So many times when the inferior turbinate has been partially resected or completely resected, the inferior meatus is actually quite widely exposed and readily able to be accessed with a spinal needle, a long spinal needle that we often use in the clinic, and an injection material. So that's fairly easily able to be accessed. But then when some special patients who really know their nose, again, these patients are very knowledgeable about what's going on, they've often place cotton at home in their nose, and they say that if I put cotton also in this 12 o'clock position in the nasal vestibule or along the nasal septum in this case, I feel a lot better as well. So in those cases where the patients may have a specific, second site that might be helpful to them, I do inject a second site with the same gel filler.
And your study shows improvement in these patients across a variety of outcomes and metrics. You didn't restore them to necessarily normal values or norm population values the way you describe it in your manuscript, but you did have substantial improvement, even clinically relevant improvement.
Right. So we just what we always want to do in our group is make sure that we're doing something that's logical, that has some data driven behind it, because so much of empty nose syndrome, in our opinion, is a little bit voodoo, and that's not going to help us. We need data-driven management, and we need to know what's happening in these patients and follow them, and again put numerics to things. So first we came up with this empty nose syndrome 6-item questionnaire, the ENS 6Q, and those are 6 we think very relevant, validated questions that help us really track the ENS population over the CRS, or chronic rhinosinusitis population. So these patients then all had scores. I think we had 13 to 15 patients in this study. They came to us from various locations in the U.S., and then their general score was, out of a score of 30, which is horrible ENS, the average score was about 20, so really bad ENS. For reference, a score of 0 to 5 is normal, normal breathing. So having a score of anything above 11 is considered empty nose syndrome on our scale, especially anything above 15, but these scores on average were about 20 to 21. And we dropped them, that score, just by doing the injection within a month. We, again, do online scoring, all this highly encrypted scoring sheets that we send to patients, and no one really remembers what circles that they circled typically, what answers they circled. So it turns out that they all dropped. The average patient dropped to the score of 10. Not normal, not in the 0 to 5 range, but they dropped to 10. So they dropped a significant percentage drop, and both for those, especially for those 6 questions. And we weren't sure that they would do that, but by doing those numerics, we now understand that putting that gel-based filler speed bump, in a way, in the nose, even if it lasts for a few months, gives them a sense of improvement in their quality of breathing. Their ENS symptoms all drop. And that's just by putting a small swell body, in a way, in their nose where the turbinate tissue used to be. It therefore suggests... Go ahead.
I'm sorry. I was going to ask you, what proportion of those 15 patients, do you recall what proportion of them had a minimal clinically important difference? I guess I'm wondering, yes, you took the average, you took the mean from 20 to 10, right? But what proportion had an MCID change?
Right. No, I think of the 13 to 15, I think we had the majority. I think 10 to 11 had that MCID. But yeah, right.
2/3 of the patients had an MCID, which
I think that's fair. And then naturally, for empty nose syndrome, there are some who don't improve and don't sense that really helped them, and we included them as well, right? We wanted to make sure they would probably be terrible surgical candidates for something more permanent, that particular patient population. That's exactly right. So, I mean, because, when I started this 5 years ago or so, I didn't know where to go. I would do things like I'd examine people. I'd do these things called cotton tests in people, and then whatever they said, I would just say, I would believe them, and we'd go. Now
you got to jump, right?
Yeah, right.
At some point, you just got to take the leap of faith.
Right. No, that's right. And then I realized, there were 1 or 2 patients, when you start out, they're like, I'm not happy. Take out the implant you just put in. I'm like, but you've passed all my tests at that time,
right?
And now what? Now this isn't right. And then when Andrew Thambu came to join our fellowship and join our program at Stanford, he challenged me to let's make this much more quantitative, and he's right. And we together came up with these metrics that we then validated, and now you have to be we validated a cotton test and a scoring system, and now you have to therefore have empty nose syndrome on a certain level, again above that score of 11 out of 30. You have to improve with a cotton test by at least 6 to 7 points. If you aren't, then you might have empty nose syndrome, or you might have cognitive behavioral issue that needs to be addressed as well. You might have something totally different. You might have true sensory loss that can't be explained at this point. But that means that at least a surgical procedure at this time is probably not going to benefit you, and let's not go down that road. And if we're not sure by both of those tests in the office and over time, then let's do the gel. Yeah. And let's see how you're doing. I mean, I could share stories if you want, but there was a patient who just came to me from Israel, and he's already had 3 nasal procedures, and each one made his breathing worse. And so then now he's come to the U.S. and was seen in I think in Southern California for he's going to have a 4th procedure on his nose now, a revision septorhinoplasty procedure and augmentation grafts, lateral crural strut grafts, and things like that. And then one of our rhinologists, I think Jeff Sue, actually at UCLA, met him and said he should come up and be evaluated by me, which I appreciate very much. And so before that surgery, he came up to see me, and I must say he wasn't the most compelling when I met him. He was a little bit despondent. He was very frustrated with his care, unhappy with all aspects of his breathing and his sleep. His scores were right on the margin, 12s on my score out of 30. Cotton test, he said it may have helped him a little bit. He was very resistant to the whole thing. But then I actually took the cotton plugs that I placed out of his nose, and he suddenly said, "Okay, I have to admit, that's a lot better when I have resistance to my nose." And then because, again, I now wasn't sure, I then recommended that we do these gel filler injections. And so we did that the next day because he was from out of town. And then he just called. He called within a week and said, "This is the best breathing I've had in years."
You're describing almost what might become appropriateness criteria for the surgical management of empty nose syndrome.
I think that's totally fair, Tim.
So rather than it just being this sort of gray, judgment of the surgeon, which there still is a lot of that involved. I don't mean to discount that, but it's nice to have some quantitative measures and some testing and some things that we can do and say, these are going to be the best patients. These are going to be the most appropriate patients.
No, that's right. And so again, and no one wants to do, procedures, especially I think in these, in a challenging population where I might be the 4th surgery that makes him no better. It might even make him worse.
Yep. And that's just a no-win situation for anybody.
And instead now he's so much more confident that this is the way next step for him. I'm more confident that he can actually improve. He might not get an A, but he can improve metrics in his quality of life. And now we're planning on doing the implant surgery based on this speed bump in the gel filler injection. But we have to wait 3 months. I told everyone we have to wait 3 months until the entire filler material has resorbed before we proceed on with any other procedures. But also we're making sure we have all the data points. We try to give 1 week, a 1 month, and a 3 month questionnaire filled out on every patient. As you're alluding to, some of the other surprising things that again make me very interested in and kind of passionate about empty nose syndrome is that we try to assess what's going on with the psychological and cognitive aspects of this syndrome, because again, I think to be fair, we as a field have marginalized a little bit of the patients in this group because they present with so many overlying nasal fixation questions and concerns, but also so many psych-related concerns that physicians kind of move them in the see neurology, see facial pain, see psychiatry. So unexpectedly to us, or maybe what we're finding that's becoming more and more the norm, is that once patients are breathing more comfortably and breathing more normally, as we show in our paper, that their anxiety scores drop from their baseline to more normal range. Their depression scores really improve as well on a significant level, on a numerical significant level. So, and these then return to baseline once the gel filler has been resorbed. So, in support of some of the things we're doing is, it seems to be that I don't know any other psychiatric disease that improves with a nasal filler, right? So it makes me much more supportive of the idea that the turbinoplasty procedure that led to that contributed to this, or maybe seems to have initiated some of this cascade of symptoms. When it's reversed, potentially, many of the psychiatric parameters, at least to some degree, seem to improve. And now that we're doing these implant procedures on a more permanent basis, which publication which is hopefully coming out soon, we're seeing a parallel to what we're showing with the gel, that a lot of the parameters,
right.
the psychological parameters, also seem to improve once the nasal breathing improves.
So now the skeptical listener is going to say, okay, your trend in improvement does follow the trend we would expect from a resorbable temporary material being injected. So they have improvement over 3 months, and then that improvement regresses back to where it was. That also follows what we might see in a placebo effect, and your study is purely observational without a control group. What do you think about the idea of doing a randomized controlled trial where you randomize patients to either filler or saline injected, something that would resorb quickly,
Sure.
and see if there is proof that there's a difference in this technique? How does that
Sure.
How does that strike you?
Certainly, whenever I can, I try to have a matched, randomized control group, whenever I can. The problem is, again, like what I was introducing before. Patients are coming in. My record is something over 30 surgeries. I take it back. Over 30 physicians that patients have seen all throughout the country and world sometimes before they sometimes come to see me. But the usual is something between 4 to 8 physicians that they've seen. So every visit, I think, to a doctor becomes more and more high priority, more and more anxiety provoking. Is that doctor going to help me? Is that visit going to be worth my time? And again, patients are flying in from all over the place to receive our opinion and the opinion of a few other doctors, again, who are trying to treat this condition. Therefore, it's hard to, although the patients understand the controversy, understand the need to do trials and things like that, none of them want to be receiving the placebo, right? When I describe it to them, they're like, look, I can't come back for 3 months. I can't come back for 6 months because of the restrictions in travel and my job and whatever. So, can you please just make sure that this helps me before I proceed on and plan a surgery, potentially? So it's hard to do that unless the patients are local. And I agree. And I do have, thankfully, a bunch, maybe not so thankfully, but I do have a fair number of patients who are local. And so now that we have this proof of principle down, I think the next step would be trying to see if we can, in a small subset of patients, probably who are easily brought back to the clinic and or easily followed, who aren't, again, sometimes paying cash or sometimes traveling from distances. Maybe we'll try to randomize that group because if we do show the same kind of trend, then we can later go ahead and inject them again, and they won't be anticipating of the result or won't be so much effect to the timing of their care.
One last question for you, Jayakar. Given what you've learned in seeing this patient population, a large number of these patients, what would you, as a surgeon, never do in someone's nose in an elective procedure? Now, sometimes people need their turbinates removed for a variety of different reasons. There are tumors, there are other disease processes that might necessitate that. But in an elective surgery where you're treating someone for nasal airway obstruction and you're doing septum and turbinate surgery, perhaps you're doing sinus surgery, what would you recommend that our listeners avoid doing in order to avoid empty nose syndrome?
Sure. I get this question more and more these days, naturally. My overall teaching to my residents and fellows and those who come to attend talks in various places is that the contour of the turbinate matters. There's a reason that virtually every large animal species I know of has turbinates. Rabbits, mice, rats, dogs, sheep, we, humans, we all have turbinates for a reason. So they must be important in overall aerodynamics of the upper airway. So therefore, the inferior turbinates, even though they might get hypertrophied and diseased and cause nasal obstruction, limited procedures to just reduce the size and improve breathing might be needed in humans for quality of life, but the contour clearly matters. So what I try to do is I only do submucosal resections for elective procedures, make a small incision in the anterior heads of the turbinates, sometimes remove the underlying bone, especially when it's highly ossified or really dense, and then just do a very gentle medial soft tissue leaflet resection of the submucosal dense tissue of the inferior turbinate and leave the entire tubular shape intact. The torpedo-like shape of the turbinate should be intact at all times. Sometimes we do these extended procedures called megaantrostomies or medial maxillectomies, and where the central aspect of the turbinate is removed. But I try to make that a very perpendicular cut with a curved beaver blade. A little technical there, but the point is that I try to leave as much of the anterior head, the front part of that turbinate, intact as much as possible. And the rates of empty nose syndrome, I think, so far is 0 for these turbinate-related resections that are needed for this maxillary sinus in those cases of tumors and chronic rhinosinusitis that some of us treat. The point is that I think that shape matters. It's just you're getting out the hypertrophy, you're getting out the enlargement of the inferior turbinate, but not affecting its overall aerodynamics.
Right. And I would add that what I've seen is that head of the inferior turbinate is almost sacrosanct. If you're going to resect a portion of the inferior turbinate, try to spare the head of that inferior turbinate. I agree with you on the endoscopic medial maxillectomy or the megaantrostomies. You can really get away you can really save the anterior half, certainly the anterior third of the inferior turbinate, and I don't see this problem in that patient population.
No, that's right. I'm shocked that how effective that procedure is and how few complaints of nasal breathing that we receive. And also, when you think about it, this article about the submucosal fillers was essentially bulking up the anterior part of the nose right behind the nostril. That's where we injected, right where the anterior head sits. And the values that we had and the numerical values of satisfaction for breathing and loss of anxiety, even loss of a sense of tense feeling that they have and dissatisfaction with their breathing really improved just by putting that front speed bump in the side walls, but the front side walls of the nose. So I do think that's the idea of this, and that's what we're really finding out.
You have some beautiful pictures, photographs in your manuscript so that the listeners can log on and visit the website of the International Forum of Allergy and Rhinology. Jaykar's manuscript is there and is currently available online, and these pictures are in color, and it's beautifully illustrated in a live patient, actually. These aren't schematics. These are actually patients that the procedure's occurring in. Well, listen, Jayakar, we should probably wrap it up there. Everybody's probably made their commute to work by this stage, at least let's hope so. But thank you so much for your work in this very, very challenging clinical problem that affects a lot of people, and I'm sure that they are just so happy to have folks like you and the others around the country and around the world who are working on this in their behalf. And so thank you for coming on the podcast and sharing your research with us, and I look forward to talking to you again in the future, Jayakar.
Well, I thank you so much for the invitation. I really appreciate the trust of this group of patients. I mean, they've been through a lot, and the fact that they're willing to come out and receive our thoughts on this and our evaluations really means a lot to us. And also just the increasing positive reception from our community in ENT and rhinology has been greatly appreciated. And so thanks to my team for this interest in this kind of research. And again, the readership and the group at IFAR, ARS, and other societies who are kind of trying to advance this work with us. So it's been a fun journey so far, and but I appreciate you reaching out and inviting me to do this podcast with you.
Yeah, just keep the journey going. It's a necessary journey, I think. Take care, okay, Jayakar?
Thank you so much, Tim. Take care.
Thank you for listening. Scope It Out is a co-production of the International Forum of Allergy and Rhinology and Wiley. All opinions in this podcast are those of Dr. Smith and his guests and do not necessarily reflect those of Wiley or of the sponsors.